introduction. And after a cutting edge lecture, I'm just going to approach a more sort of a very simple, practical approach to how to manage our patients in a day-to-day practice, especially in Southeast Asia. Quickly at this gentleman, our day-to-day patient in our clinic, a 55-year-old man with type 2 diabetes, got it at the age of 40, and he's on these medications, BMI 27, blood pressure not too bad, but 145 by 90. Mild retinopathy is there, not a smoker, HbA1c 7.5, for microalbumin 270. Familiar? I mean, day-to-day practice. So how do we, are you happy with these numbers? In hundreds of patients in our clinic, part of the world, and phenotype, and most of them have much worse numbers than this. Reasonably okay when you compare the others, especially in Sri Lanka, in our government clinics. But does he have diabetic kidney disease? What do you mean by diabetic kidney? The clinical diagnosis, mainly in people with diabetes with albuminuria or reduced estimated GFR. It's very simple. When an alternative renal pathology is clinically unlikely, you don't have to do renal biopsies or lots of testing or even ultrasound scanning to diagnose diabetic kidney. So it's a simple, I would suggest a urine full report and a urine for microalbumin or a ACR, whatever you do in your clinic. But there are caveats. Might have to repeat that. And the blood sugar control should be less than 200 when you do it. There should not be any precipitation or any other factors or a UTI which may give a falsely high value. So it's good to get these caveats and then properly label them as having albuminuria. And of course, the EGFR, you all know how to get it. And consider scanning only if there is a rapid decline of the EGFR, proteinuria more than 300, current UTIs, suspected nephrolithiasis or any other complication, active urine sediment. How many of you carefully look at the UFR report for the sediment? Please get that. So that's a trigger that you might have to do ultrasound scan in your patients. And of course, very high pressures. Free drugs, medications, still the blood pressure is not to target, then you could, do an ultrasound scan of or a ultrasound KUB. I think this is a very useful latest KDIGO classification, which simplifies for our doctors. I have it on the tables of my junior doctors in my busy clinic, and this summarizes the grading of the according to the GFR, the CKD, and the proteinuria, and you will know, looking at the values for your patient, when they should be started on medication, when they should be referred to an expert or nephrologist, depending on the local guidelines, and how often you review them, whether it is every 3 months, once a year, every 6 months. A very useful guide and a summary for you to follow your patients with diabetic kidney. So what are the measures that can have? We say the 4 pillars. Of course, glycemic control. Although we say don't be centric, that's still the crux of the matter in most of the cases. You have to control, but it's not only controlling the blood glucose levels that will the job for your patient. Optimize the blood pressure control. Then, of course, the ACE inhibitors and the ARBs and the SGLT inhibitors. These are the sort of the 4 pillars that you can talk of. But now there is evidence for GLP-1 receptor agonists. I will show you the evidence there. Not only cardiovascular risk reduction, but there is renal risk reduction as well. And the latest non-steroidal mineralocorticoid receptor antagonist, finerenone, I think it's available in India, although it's not there for us. Spironolactone, the older medication. And of course, about the protein. Moment you see proteinuria, sometimes even our junior doctors might drastically reduce their protein intake. That should not be done. Can take up to zero point 0.8 milligrams per kg of kilogram of protein for a day. The flow trial which showed us that GLP-1 receptor agonist, apart from the cardiovascular risk reduction, there is renal risk reduction as well, 24% reduction in the risk of kidney-related events in people with type 2 diabetes. And of course, a good diet, the dietary advice, the proteins I mentioned, less than 5 grams a day of salt, and the potassium and the high fiber diet should not be restricted unless there is advanced kidney disease. Potassium is high, then you could avoid the that are high, rich in potassium, and of course get a nutrition help, the ADA side, but we need to match it with our local regional food items that our patients. For glycemic control, now the first pillar I was talking about, what are the measures? Usual stuff, but if you have a choice, I would say after metformin or even without metformin, SGLT2 receptor uh, uh, inhibitors and GLP-1 receptor agonists can be taken, cost permitting, depending on the area that you are working in. But unfortunately, some parts of the world, including Sri Lanka, we don't have that luxury. We have to follow the normal sulfonylurea, metformin, insulin sometimes, and the DPP-4 inhibitors in most of our patients due to affordability issues. But still, with whatever the medication that you control the sugar, it will help. But the added benefits will be there with some of these medications. Then the question comes, which medicine be altered when there is a drop in your patient's EGFR? This will summarize, as you know, metformin. Some of the doctors, microalbumin positive or albumin in urine, they tend to stop. This in my country, the metformin, saying something renal toxic. That should not be the case. Can go down even up to EGFR of 30. SGLT2 inhibitors can go down up to a EGFR of 20, and the GLP-1 receptor agonist up to 50. Don't have to reduce. Of course, sitagliptin and other DPP-4 inhibitors, other than linagliptin, have to reduce the dose. These are the 4 pillars that I was talking about in reduction in diabetes complications, patients, and of course, when it comes to patients treating with nephropathy, this slide will summarize all the measures that you should take. I have said before, you have a choice, can start with metformin, SGLT2 inhibitor, GLP-1 receptor agonist, then other medications to control the sugar. Then the blood pressure, ACE inhibitors, ARBs, calcium channel blockers, and if available, renal is a drug. Nothing is working, even processing, the common drug that we, and of course cardiovascular risk reduction with statins and aspirin as the indication may be. So the new studies, all of you may be familiar, Fidelio is not very new, Fidelio DK study which showed that finerenone over and above what given with SGLT2 inhibitors, over and above the reduction what is seen with SGLT2 inhibitors, there will be reduction in the proteinuria in your diabetic patients. And this Figaro DKD study shows that there is cardiovascular reduction in type 2 diabetes patients with CKD when you are using this medication. So have an approach or availability, the newer agents, which should be helpful in reducing the overall cardiovascular and the renal risk in your patient. After managing and giving all this, when should you refer to an expert or a colleague or your patient? I told about the urine treatment, hematuria, CAS, worsening proteinuria despite all of this nephrotic range proteinuria, accelerated hypertension, and a steep fall of your EGFR rather than the expected. There are nomograms which we can follow, and absence of retinopathy in type 1 patients, not type 2, not always related, but in type 1 patients, think of other primary renal causes which is causing the problem, then you should. And generally, when the GFR drops to less than 30, I usually get a nephrology colleague to review the patients and give their opinion as well. And if their pressure is high, how do we manage? The ADA 2026 and all other organizations, it's ACE inhibitors. If it is pressure is more than 150/90, they recommend start with 2 medications, preferably ACE inhibitor, ARB, and combine with a diuretic or a non-dihydropyridine calcium channel blocker. Then comes again the finerenone and the other drugs. And processing, commonly used in Sri Lanka, I don't know the availability, is a good drug when there is resistant hypertension, there are patients with diabetes and renal disease. And again, depending on the EGFR, you might have to, change these medications and the targets. With proteinuria and diabetic kidney disease, 130/80 would be a good target for you. And without proteinuria, even 140/90, less than 140/90, would be okay for your diabetic patient. Coming back to our patients in a routine clinic in a government setting. So this is what we did. We added empagliflozin. We don't have GLP-1 receptor agonist, and increased the enalapril and added amlodipine. Control his pressure. Marginally high, but then it was not target. And 3 months later, when he comes to the clinic, you can see the difference. His weight has come down, especially Southeast Asians I have seen with empagliflozin, the weight comes down. They respond very well to this medication, and the sugar control is not optimal, blood pressure is optimal, and his lipid profile is given there. Can we be happy? Think about it. And of course, the typical liver enzymes, the fatty liver, NASL, which I don't have the time to discuss. So are you happy with this glycemic control? A young guy, less risk of hypoglycemia, educated person, we could do better. Can push for 6.5, fasting 80 to 100, and postprandial less than 140. Still, his parameters would improve. And lipids, total cholesterol of 195, and he's now 55 years. He was not on a statin. LDL was 100 plus something. We do better? Yes, that's what the guidelines say. Anybody above 40 have moderate statin anyway. Even if he was less than 40, with the added risk factors of proteinuria and the hypertension, he should have been on a statin. We did added, and then the moderate intensity statins would be the way forward for him. The products are given there, the doses that you can go. High intensity, Southeast Asians, I don't know. I rarely go to 80 because they get severe muscle and the side effects with 80 doses, but I'm very comfortable with the moderate intensity statin doses that are given there. And the LDL targets, no established cardiovascular less than 55, and if there are two risk factors less than 70, and even a young person with type 2 diabetes, try to keep below 100 for your patients. You can't achieve that with a statin, improve it trial. I mean, we have ezetimibe. It's cheaper, we use it regularly, but the other newer medications are beyond reach for us in this region at the moment, I guess. And the triglycerides, are they innocent? No. Look at the values and treat them. At fibrates at a level of about 100 to 500. Above 500, reduce the risk of pancreatitis. Add high dose oil. We have patients with thousands, I think the familial ones, where we do plasmapheresis and dextrose infusions regularly to keep the triglycerides levels down to prevent pancreatitis. Ladies and gentlemen, with this reduction of cardio-renal risk in your diabetes patients, with these themes, all the major organizations now recommend recognizing your patient's risk factor, individualized management, and look at whether they are having heart failure, established atherosclerotic cardiac disease, or vascular disease, or CKD, and treat the patients accordingly with all the problems like tirzepatide, the twin cretins that we have. To reduce their weight, most of them are overweight or obese, we can tackle most of these problems in our Southeast Asians. Availability and the cost, as Niti said, if we had insurance and had the approach to these medications, that solve most of our problems, but unfortunately, not at the moment. He asked me, Doctor, can I have aspirin? Should I take aspirin? How do you answer that? We have the WHO Southeast Asia category chart, put his parameters. 10-year cardiovascular risk came as 10%. It's a bit controversial. The ADA latest 2026 says even that they don't give aspirin now unless he has two established atherosclerotic cardiovascular, one vascular bed or two, then you can start. Otherwise, it's statins, SGLT2 inhibitors, and GLP-1 receptor agonists. So, ladies and gentlemen, this is the way, in a practical way, in your day-to-day clinic, that you can reduce the cardiorenal risk of your diabetic patient. Thank you very much.
Thank you, Dr.